Yes. Right. So, if you're just joining, it's a pleasure to come your way again today. Good evening. Anywhere you are watching us, it's an amazing time. This is our third webinar in the Prevent First Commission Preventive Health webinar series. And today is going to be an amazing time. But um, if you have been joining us since our first webinar, you testify that we have had facilitators who have really informed us, given us a great insight to really be able to live our lives in the way that we're supposed to live, especially in this COVID situation. Now, today, um, we have the pleasure to talk about a very sensitive situation, especially in this pandemic situation where COVID-19 is changing a lot of things in our lives. And we're going to talk on the theme, how to talk with the public and media in a health crisis. As you know that we are in a health crisis, we are in a public health crisis, and in any crisis situation, you realize that people taking information, they process the information, they act on information differently as you find them responding to such information in a non-crisis situation. So that is why it's a pleasure to have Dr. Robert Bernstein to talk to us more about how to communicate and talk with the public and media in a health crisis. Now, Dr. Robert Bernstein is an adjunct associate professor of global health at the Rollins School of Public Health, Emory University in the United States of America. And it's a pleasure to have him. He is having experience in these situations, in global health issues, and especially in situations where you can communicate with people in crisis, instances. And if you just join us, just stay tuned. You can share the link to your friends to also stay tuned with us. You can also send in your questions in the comments box. Dr. Bernstein is ready to answer all your questions. If you are watching us from our YouTube page, you can also do so. If you are listening to us on Radio Power UA, you can send in your questions in the comment section as well. Then we read it out for answers from Dr. Robert. It's a pleasure to have you. Stay tuned and enjoy this session of the webinar as we invite Dr. Robert Bernstein to take us through.
Well, thanks very much indeed for your invitation, Peter Sarpong. I want to acknowledge Peter and the work of the first commission, the Prevent First Commission, and also the European Medical Students Association, as well as Radio Power UA for the opportunity to speak to you or to discuss with you today. I don't want to be just speaking to you, but I want to be listening and participating with you in this discussion. I also ought to say that all four of my grandparents were born in the Ukraine, so it's a treat for me to
That's great.
to be speaking with you folks. I also want to make it very clear that what I'm going to be presenting is the result of my review of a large amount of very important work by professional colleagues at the Centers for Disease Control in the U.S., the Environmental Protection Agency in the U.S., the World Health Organization, and the U.S. National Academy of Science, Engineering, and Medicine around the world for their research and publications on three key topics related to this presentation: health literacy, health risk communication, and vaccine hesitancy. Three very important areas in the technology and the potential success or lack of success in health risk communication. You'll hear the term SACO from time to time. It's the acronym or abbreviation for the phrase single overriding communication objective. SACO, single overriding communication objective. And on the first page of my PowerPoint, which I hope everyone can see,
Yes.
Do you want to take a moment, Peter, and make sure everybody's able to be able to see who's participating? On this first page, the quotation from the publication by Dietram Schufel, hope I'm saying that correctly, and his colleagues, How Not to Lose the COVID-19 Communication War. That quotation represents my sacco for this discussion. And that is in the midst of the COVID-19, what WHO has properly called an infodemic. Um, in the midst of this infodemic, efforts to counter misinformation and disinformation by narrowly focusing on accuracy and the facts are likely to backfire or at least not be as effective as one would like. Evidence and information not likely to be as effective as we would like. And the reasons for that are that scientists, policymakers, journalists, anyone who has a role in trying to convey and convince health information, risk communication, has to attend not just to the accuracy of the facts, the evidence and information, but to the social values of the audience, cultural and social values of the audience, their perceptions, and scientific uncertainties as well. And I think in general, that's done very well by the agencies and institutions that I mentioned, from whose work I've drawn the material for this presentation. Um, the Lancet series, the Hopkins work, and so forth, all have been very valuable. Let me stop right there for a moment and see if anyone has a question about what a SACO is and how to use it, how and when to use it.
Well,
Oh,
I
by the
think if
way, I insist that people interrupt me from time to time.
sure, sure. You're going to be
so,
interrupted a lot of times. So I think many people will find it very, very new to them. You know, so maybe you may want to elaborate in more, maybe their functions. I mean, what they are involved in as well.
okay. Thanks. Sorry for that. I should say something about my background. Um, so started my public health career as an epidemic intelligence service officer at the U.S.
Okay.
Centers for Disease Control. Some of the participants may be trainees or graduates of field epidemiology training programs or FETPs that are like the CDC's EIS or Epidemic Intelligence Service.
Mhm.
I was director of the field epidemiology training program together with the Ministry of Health partners in Indonesia and in Saudi Arabia. Um, so my education includes a PhD in molecular biology, biochemistry, and postdoc in pharmacology at Yale, and then medical school and a public health training. And my medical degree includes a post medical training in public health and preventive medicine. So maybe that's how Peter found me. I'm not sure. But I should mention my first opportunity or assignment in risk communication, and that was hundreds of years ago. I was, as a new EIS officer at the Centers for Disease Control, I was assigned by CDC together with a team of epidemiologists, health professionals, um, uh, to assist the Federal Emergency Management Agency, FEMA, to respond to an explosive eruption of the Mount St. Helens volcano in the state of Oregon, state of Washington, rather. And that explosive eruption affected thousands, tens of thousands of people in the states of Washington, Oregon, and Idaho in particular. Um, so I was the CDC representative and public health slash medical advisor for the Federal Emergency Management Agency office that was overseeing the response to that emergency by a wide variety of government, non-government, community-based, faith-based, other organizations that were assembled together to address this problem. And two of the most interesting things, maybe two or three of the most interesting things about that experience were First of all, the fact that I was to be the advisor for the volcanologists whose job it was to, among other things, to fly in a helicopter and land on the volcano on a daily basis to
Wow.
take its temperature and decide what it was going to do next. Of
Wow.
course, my advice to them was not a good idea. Don't do that. But because they had to do that, I just accompanied them, and that was an amazing experience. Secondly, I had the experience as a new epidemic intelligence service officer to hold public briefings every day for the media and the public and professionals. And that was my first opportunity to try to learn something about SACOs. I wasn't very good at it at first, but hopefully I learned over time. And finally, that assignment was a remarkable experience for me because I uh, sat in a small room with the President of the United States and the head of the volcanology service and the Corps of Engineers and several four other individuals um, in order to brief the president on the nature of volcanic ash and the physical hazards that were taking place and what, from a public health perspective, what could be done to try to address that unpreventable problem. So that's background.
That's great. That's great. That's very insightful.
I have worked in dozens of countries in Asia, Africa, Middle East, and Eastern Europe over the years, and only been to the Ukraine on one occasion, but that was just for a short visit. I hope to
Okay.
get there again. So why don't we get started? Unless
Right.
there are some questions before we start with more of the slides.
No, not yet. So I think we can proceed. Proceed.
Okay. So you have a way to see questions as
Yes.
people are
Yes,
putting
I
them in.
do.
Okay, great. All right. So again, my SACO, the accuracy, the evidence and information, the facts, not enough. We've got to be thinking about social values, perspectives of individuals, cultural issues, and so forth. So let's take a look at this next slide. I drew a lot of information from the Centers for Disease Control's Emergency Partners Information Connection and an EPIC seminar that they held just recently on the 24th of June, which, as you can see and you can make note of, so that you can download the webinar itself and the transcript if that was of interest for you. You'll see in the notes for that left-hand page, that part of the page, that the webinar was to provide answers to a series of 10 broad questions, 20 broad questions that had been submitted either by the public or professionals to the Centers for Disease Control. But by the time the 1 hour webinar was over and those questions were addressed, and again, you can see that or see the transcript, by the time the 1 hour seminar was over, more than 1,000, I think 1,200 additional questions had been submitted. So being prepared to and capable of and knowledgeable in addressing health communication, risk communication issues in this time of the coronavirus pandemic health crisis is really important. And on the right-hand side of this page, the image there is Dr. Robert Redfield, the director of the Centers for Disease Control, who's properly wearing a face covering at a presentation for the U.S. Congressional House Committee on Energy and Commerce. Thank goodness leaders of that type do wear face coverings when they're in public settings and exercise physical distancing. But the point that he's making there is extremely important. This was just the day after the EPICS webinar from the Centers for Disease Control. And he's pointing out that in all likelihood, there are perhaps 10 additional individuals for every individual whose test has proved positive in the United States, or certainly in parts of the United States, depending very much on how transmission is going there. So his sacco was, it's not over. Um, Wear your masks, facial mask, use physical distancing, adhere to respiratory hygiene, hand hygiene, adhere to the principles of public health that are so important before we're able to have a safe and effective preventive vaccine. Um, and so the magnitude of the problem in the US has not stopped, unlike what has been said by some leaders in the US. And it's not as well controlled as has been implied by some leaders in the US. Let's go to the next slide. Any questions about these two images?
No, no, you can go ahead, Dr. Bo.
Come on, everybody, let me hear some questions out there. So these two slides are really a key part of the reason why this webinar, perhaps in Peter's mind, was important, but certainly in my mind is timely and important. And that is, experience has shown in emergencies and disasters in the past, from way back, from communicable disease emergencies, non-communicable disease emergencies and disasters, terrorist events, whatever the nature of the emergency or disaster is, that there's a series of principles um, that should be adhered to in providing risk communication and providing health and safety advisories for the media, for the public, for professionals, um, for those who need to know. Um, but over the years, since the internet has become available, um, that use of um, good experience, lessons learned from good experience, evidence and information, presentation of evidence and information has proven not to be sufficient. Um, I'm not sure for all the many participants, either from Ukraine or other countries, what the situation in your area is with respect to vaccine hesitancy for routine, well documented, safe and effective immunizations, vaccines. But certainly in parts of the US, there are clusters, areas of communities, and even a national movement of anti vaccination um, perspectives that are unfortunately ill informed but strongly held. And a recent publication from the Sabine Aspen Institute reviews very carefully and very comprehensively the root causes of vaccine hesitancy, but winds up finding that much more research and applied research and efforts are needed to be able to effectively communicate in the context of the strength of the mis and disinformation that is so easily obtained and so frequently obtained and um, apparently so enamored by large numbers of people all over the world, as you can see in this image. So on the left-hand side, evidence and information from experience on um, how to be responsible and how to be effective. Um, there is a worksheet on how to prepare a SACO briefing that you'll see the link for later on. Um, but on the right-hand side, there's the problem of overcoming mis and disinformation that is now so widespread. And when, I should say, if and when, hopefully, when a safe and effective vaccine to prevent infection with SARS-CoV-2 and cause COVID-19 disease, when a safe and effective vaccine becomes available, get ready, folks. If you're a health professional, if you're a vaccinator, if you're involved in the public health system in any way, you need to begin to think now about how you would address concerns on a COVID-19 vaccine. The last slide in my presentation you'll see is a couple suggestions on how Prevent First Commission and the European Medical Students Association might think about having some scenario-based training for public health professionals to prepare for this. Okay, we're going to go to the next slide unless there's
Right.
questions. What do you think, Peter?
The anti-vaccine extremists, what are they demanding, or what are they trying to prevent in that situation? People who are in extremism of anti-vaccines,
Sorry, say that one more time.
right? So people who are anti-vaccine extremists, what threat are they posing, or what are they doing to, I mean, pose such a public health intimidation now?
Okay. Well, as you can see on the slide, on the image, they gather and protest in a variety of ways. Um, and this is not just limited to anti-vaccine protests, but for example, anti-physical distancing protests, anti-masking protests, some of which become violent. And in fact, in California and across the US and perhaps in Europe and other places as well, a number of health professionals have been threatened um, and intimidated um, at their homes or at their workplaces and in emails and so forth because of their efforts to help people understand what will work and what won't work in order to prevent disease through immunizations or in order to prevent infection and disease through physical distancing and use of masks. And they do this on the internet. They do it in physical presence at the demonstrations. They do it by letters in such a way that there have been a number of resignations of health professionals across the state of California and across the US as a result of this. So when I say get ready, I mean get ready technically to be able to thwart the arguments, the perspectives, by listening carefully, trying to understand the root cause for a particular perspective, trying to appreciate, if you can, what the source of mis or disinformation has, what impact that's had on the perspective of the individuals who are protesting in front of you, or the client who's brought their child or not brought their child to the clinic in order to get immunized, or has brought their child for some purpose but doesn't want to get an immunization. So um, be thinking in advance. It's going to be important responsibility of government, non-government organizations, faith-based, community-based organizations to work together, stakeholders, hospitals, services, and so forth, to listen to the concerns of the anti-vaxxers, the um, hesitants, and try to figure out ways to overcome mis and disinformation. Not
So
necessarily
I
easy
think,
as demonstrated in the Sabine Aspen document.
yeah, I think so. I think before you proceed, I think it will be one of the things that you may want to talk about, especially when it comes to vaccination. I think the communication by, I mean, policymakers and all that. I think it also affects the individual's willingness to undergo vaccination. For example, recently we had this tension in some countries in Africa where there was this alleged attempt by some French scientists to go and test some vaccines on some people in Africa. So I think it's that communication issue rather incited some level of tension among, I mean, some countries in Africa and an attempt to resist any vaccination programs and all that, right? So I think the communication is going to help in any way, and I think that's one of the reasons why this webinar is really timely as well.
Okay, well, thanks for that, Peter. I think a good time to talk about that would be at the last slide where I propose a couple of practical exercises um, that might be organized at the level of a medical school or by a public health department or by an organization like WHO or CDC or some other organization. So let's go on to the next slide, unless there's something else, Peter.
No, it's okay. We can go on.
Okay, so now we begin a series of slides in which I would like to not read word for word, but refer to one set of important materials that I would propose as important training materials and lessons that have been learned in order to provide an effective, in order to plan, design, implement, monitor the implementation, and evaluate the effectiveness of a health communication, risk communication strategy or message. Um, we in the United States are unfortunately having some serious problems because of differences in the way that our political leaders, some of our political leaders, uh, are uh, not yet ready or not yet comprehending or able to comprehend what the scientists and public health professionals are trying to tell them or influence their decision making and policy making. So in these slides on the left hand side, you'll see examples of the 7 cardinal rules for health risk communication in emergencies, disasters, and other health crises. And on the right-hand side in each of these slides, you'll see some images and some information about difficulties that we're experiencing in being able to implement those rules of communication effectively. Um, so underneath the right-hand side images, you'll see a small paragraph, and I'm going to read that one um, because it comes from some information from the Centers for Disease Control that I find very valuable. So this just reminds us that the purpose of a health risk communication briefing is to provide a clear and consistent message delivered by a knowledgeable, credible point of contact person. And that CDC has developed the SACO methodology and has a worksheet that's been developed as a tool to enable a public health professional or another person who is going to make a briefing, who's going to prepare a briefing in order to help them prepare for it. What are the components that need to be put into thinking about what the single overriding communication objective should be? And there's a link to get to that worksheet. So let's start with the 2 rules, 2 of the 7 rules that are on the left. Let me stop just before I do that. Are there some questions that came up from my introduction to this slide?
No, go ahead. But
Okay.
I think
So
the question available is related to what you're gonna talk about in the rules.
the rules,
Yes.
here they are. So here's rules 1 and 2. Now these, I'm using the word rules because that's the phraseology that was developed and used by the Environmental Protection Agency and by Dr. Vincent Covello, who has In each of the rules, there's a subparagraph in which Dr. Covello has, from his vast experience in health communications, has given some guidelines on how to go about implementing that particular rule. So the word rule, it should be taken with, we have a phrase in the US, a grain of salt. Doesn't mean that you must do this, but it's a guide. That's probably a better idea. Um, and guide number one, or rule number one, is to accept and to involve the public as a legitimate partner. And this comes back to the last images that I showed on the slide before, where the um, uh, protesters with the signs that indicate their perspective about, in that case, what was it? I've forgotten which one. Okay, so masking and physical distancing. So their perspective about that is legitimate. It comes from some cause, some source of information, some, whether it's talking with a neighbor or looking at the internet, Instagrams or Facebook or whatever, but not looking at the NIH PubMed, or not looking at the Centers for Disease Control, or not looking at their state or county or city public health websites. Or when they do look at those websites, they have been told by some political leaders that this is fake news, this is the dark web, this is um, not true, and so forth. And so they've come to have a perspective. And rule number one, guide number one, is to involve and accept the public as a legitimate partner. You've got to be able to listen, try to understand, in order to be able to understand what root causes you need to be able to overcome. And in doing that, you are demonstrating respect for the public by getting them involved, by listening to them, by holding key informant interviews. If there are leaders among the anti-vax or anti-masking, anti-physical distancing um, uh, groups in your community, if you simply try to ignore them, and when, as in the first slide, depend on evidence, information, scientific facts, um, you're going to have difficulties. So rule number one, or guide number one, accept and involve the public as a legitimate partner. And rule number two, just following on that, is when you do involve them, you've got to listen. And that means listening to understand, listening to find a way to address what, as you listen, appear to be dis or misinformation. You won't necessarily be able to overcome that by providing the correct scientific evidence and information that's been missed or dissed. Um, but you need to understand, you need to know what is underlying the perspectives that you're trying to overcome. And sometimes there are times when providing that evidence and information in a respectful way and in a convincing way. And this is one of the areas that the global, national, state, and local government, as well as public-private partnerships and um, um, community groups and faith-based groups, need to work together in order to uh, identify the root causes of mis and disinformation, and try to address that. So the next slide, or do we have some questions that came up?
Right. In regard to accepting and involving the public as a legitimate partner, um, I guess the question is, um, does that involve also accepting the, the cultural basis of the individuals that, or the public that you're going to deal with? Example that is being given is that during the 2014 Ebola virus disease, where uh, we find out that some countries in West Africa and traditional barrier practices were spreading the infection because people want to, I mean, touch and watch the bodies of people who were victims of Ebola, and you realize that the CDC stepped in to engage their health authorities and to know that they can do effective burial services, but to ameliorate the spread of the particular virus.
Yeah.
In that situation, I think the culture became such thing that needed to be taken care of in such a very good way.
Yeah.
What do you talk about the culture situation?
Thanks so much for using that example. You're absolutely right. In the first slide with the Sacco quotation, cultural should appear there as well as the other constraints that need to be paid attention to. You're absolutely right. Language is another issue. The language of individuals in a community can vary quite a bit, and public health officials themselves may not be fluent in a particular language in a particular area. We have a lot of diversity in parts of in states and cities in the U.S. I'm sure that's true in European countries and so forth. And I know it's true in Asia and certainly in Africa as well. So um, when there are cultural or language or other reasons why um, um, accurate evidence and information um, is not being understood or not being adhered to, that's a root cause. That's one of several root causes that need to be learned, need to be understood and appreciated, respected, and addressed um, in coming up with effective health risk communication. So identifying root causes includes issues around cultural sensitivity, language, and so forth.
Yeah, that's great. That's great. And I mean, talking about you talk about the issue of credibility, right? Credibility. I mean, as you build up from your audience,
Right. So I'm going
right?
to go on to the next slide.
No, there's a question
Oh, I'm
about
sorry. What was that?
a question related to credibility,
Okay.
because for example, us I mean we know the two major influences of credibility. I mean how your information should be accurate and the speed of release of that information. I think one of the major setbacks we have in communicating in this COVID-19 is the the speed of release of information um, as in contrast to the accuracy of it. And a typical example, I mean, we've had some of our audience asking is about the fact that how do you build credibility when you want to speedily give out information and also maintain the accuracy of it, especially with the hydroxychloroquine issue. I mean, the speed of release of that information, but it came out that its accuracy is being, I mean, it's not really plausible. So how do
Yep.
you combine the two?
Yep. So in that first slide, um, scientific uncertainties um, and the social and cultural values. So scientific uncertainties um, must be clear in a SACO health briefing. If there are uncertainties, and tragically, unfortunately, high impact journals, Lancet, New England Journal of Medicine, or was it JAMA? I forget now. Uh, two or three of the most prestigious and usually most highly regarded journals apparently too rapidly accepted in peer review processes and the authors, in some cases themselves, to rapidly accepted sources of information that had not been adequately verified and checked. So, evidence and information from scientists is not always perfect. And the uncertainty associated with estimates, um, uh, the range of certainty over an estimate it must really clearly be conveyed. Um, Fortunately, this is done, for example, I know in the CDC's COVID 19 tracker software, as well as in Johns Hopkins' work, the uncertainty around estimates can be viewed either in the initial charting, or you can choose to see what the uncertainties are. So conveying uncertainty is really important in a briefing, um, because science is not perfect, and but however, decisions to protect the safety and well-being of the public sometimes requires that we go make a decision, a policy or program or practice decision with the best available data. And it's just important to indicate that that's the best available, not necessarily the perfect um, uh, data that are available. But thanks for mentioning that. That's a good question.
Sure.
Shall we go on to the next one?
Yes, sure.
How are we doing on time, by the way?
We are doing pretty well. We are doing pretty well. We still have about an hour and 15 minutes to go,
Oh
so we
my.
are doing pretty
Are you providing coffee at some point?
well.
Okay. Um, so, guide or rule number three on the left hand side, opposite some examples of perhaps not adhering to this rule, this guide. Be honest, be frank, and be open, be transparent. Um, the messenger has to be perceived as trustworthy and credible. Um, when political leaders are in front of an audience together with scientists and the topic under discussion is a scientific topic, who takes the lead and how is that managed? Um, Providing examples to demonstrate honesty, frankness, and openness, such as following guidelines on wearing facial masks and physical distancing is incredibly important. And if leaders are not demonstrating appropriate behavior, that confuses the public, or at least, if not confuses the public, it encourages the um, vaxes or the anti-maskers or the anti-distancers or whatever, because they can see that some um, political leader is not apparently listening or adhering to or understanding what they're being told, and that's a problem. So honesty, frankness, and openness, transparency, key issues in preparing a health risk briefing, communicating a health risk briefing. Try to avoid um, differences between what experts are saying and what others are saying, or at least make it clear that there are uncertainties, but we're trying to encourage behaviors that represent the best available evidence and information. Any questions on this slide, on
Right,
Rule 3,
right.
Guide 3?
So I think the question in there is, I mean, how will you react to the public notion that I think most national leaders have not been open to their populace as frank as possible, because there's that notion that people or the leaders kind of massaging some figures as far as let's say mortality or even the, the infection rate, or I mean there's that notion of leaders not being open to the public and all that. I mean it's very critical to get the trust of the public if they don't find you to be open in all that. So, I mean, how do you react to that? And I mean, what recommendation do you want to give to policymakers on that?
Right. Um, well, fortunately, that problem is not um, uh, true in every national, um, state, or local government organization. In New York State, for example, the governor has been excellent. In California, the governor has been excellent. In other states, governors who initially took a particular perspective, and unfortunately, this often devolves into partisan political positions. But in other states where a position was held by a governor that did not represent good science, good public health, has changed, especially with the information most recently on the 25th from Dr. Redfield about what's happening after reopening and easing of guidelines has occurred. The evidence, the applied epidemiology evidence, um, is very clear in countries like Korea, Singapore, parts of China, parts of the United States, and certainly, I'm sure, parts of Europe, and hopefully in Africa, and certainly in other places. The evidence is very clear. Non pharmaceutical public health interventions are effective and safe. And in the absence of a safe, effective vaccine, they are our best tool, together with hand hygiene, respiratory hygiene, universal infection prevention and control practices in healthcare settings. Those are the key components of preventing transmission. So I don't think it's true that in every nation, the top leaders have, Canada, for example, excellent leadership. Um, I think in the UK, um, I haven't studied this carefully to assemble a list of national leaders who have not um, provided the best lessons learned for the public, and demonstrated consistent behavior with public health recommendations. Certainly, WHO's leadership has been key in this area. Tragically, the decision to defund WHO is foolish and can be serious problem, not only for the current pandemic but for any coming pandemic, um, because of concerns over what WHO may have done or not done fast enough. Um, so these are personal opinions, by the way. Um, uh, it's very clear to me that political leadership and leadership by non-government organizations in a university, in a school, in a police department, in any setting, whether it's a workplace setting or a political setting or a non-government, community-based or faith-based setting, if leaders are not adhering to the best possible non-pharmaceutical interventions, then their clients, their parishioners, their employees are in danger.
Right. So I think it's very common and alarming in many nations that having the opportunity to do their presidential elections this year. Because, I mean, more alarming is the fact that you have nation leaders coming out with, to implement policies that scientists do not agree, or scientists have, I mean, I mean, kind of disagreement to such. So I think definitely, as you said, not all nations are having that problem, but I think that conflict of how to maintain, political or partisan, decency, and also make sure that the health of the people is also taken care of. I think that's the challenge, how to, combine the two in most nations, actually.
Yeah, True, true, true. Um, if there are other questions on
No,
this
no,
slide,
we can
okay,
proceed.
all right. So we'll go to the next one. So guides or rules 4 and 5 here. Coordinate and collaborate with credible sources. Um, again, represented on the images on the right, for example, Deborah Birx from CDC and Dr. Fauci from NIH, those are the credible sources. But it doesn't look like there's coordination and collaboration taking place in the situations that are represented by these images. Um, and allies can be effective, but if you're not listening to the knowledgeable allies or not adhering to their advice, if there's a good reason for that, maybe perhaps there's a good reason for that. Maybe they're wrong. But in this situation, the credible allies are not always being attended to or coordinated with. Um, and credibility is so important in briefings because um, a briefing takes place before an audience, okay? And the makeup of the audience for a particular briefing has to be has to be regarded, has to be considered in terms of preparing whatever the briefing contents are going to be. Um, if you're holding a briefing for the entire um, population of the United States, you certainly would want to have the best available um, information available because of the diversity of the audience that you're addressing. Incredible diversity, total diversity. If you're a church leader in a particular type of religious organization, um, you need to understand and take advantage of information from um, members of your faith who are also experts in public health, and you ought to look for them and find them and talk to them in advance of perhaps a sermon or an address that you want to make in your church. About things like physical distancing or masking and so forth. Um, if you're an employer, and you'll see some links later on in the next to last slide, if you're an employer or an employee, there are guidelines from the Centers for Disease Control on how best to organize and protect the health and well-being, safety of your employees in the context of the COVID-19 outbreak. And these lessons that are available from CDC can be used to prepare a briefing that you can hold on a regular basis if you're an employer or if you're a union member or whatever. Um, so coordination, collaboration with credible sources, very important. Um, meet the needs of the media. Again, the media is one type of audience, and the media is not necessarily a homogeneous media. It's going to be composed of of public sector media, commercial media, um, media with a particular bias, media without a bias, media for organizations, faith-based organizations, government organizations, commercial organizations. So there is no such thing as the media. There's audiences that are going to be briefed, but they are briefed. Um, but the media audience is a critically important one because they're then going to broadcast and hope to help the people who attend to that media understand and change their behavior in accordance with what the briefing for the media has to say. So these 2 points, 4 and 5, are critically important and depend very much on preparation, taking advantage of the best possible available public health intervention, non-pharmaceutical intervention uh, um, data.
Right. So I think two questions I've gotten from the audience all I mean seek to ask the same thing about the credibility of the media. I mean, we know that, I mean, of course, as you said, the media is a prime transmitter of information. And in COVID-19, because it's novel, we have a lot of credibility issues and all that. So the media, I mean, coming in to be a major stakeholder in transmitting of information and all that. I mean, what recommendation do you want to give to the media, especially coupled with getting to know credible sources to for the media to publicize and all that? I mean, what recommendation can you give? And I mean, which credible source can you think of the media focusing on?
Well, okay. So the sources that are on the next to last slide are going to be the ones that I as a public health professional with 35 years of experience in the U.S., Asia, Africa, Middle East, Eastern Europe, um, depend on. I depend on the CDC, the World Health Organization, the National Academy of Sciences, Engineering, and Medicine, and the Gates Foundation, Johns Hopkins University. These are the sources that um, I feel are the most credible sources. Um, with the internet uh, and the partisan nature of some media organizations, um, uh, mis and disinformation is rampant, unfortunately. If there were a way to require that everybody viewed NIH, PubMed, or CDC or WHO as their source of information, that'd be great. But that's not the way it is. And so we come back to what I was saying, I think, earlier, which is that media representatives are professionals. That means that you have a professional obligation. What is that obligation? To try to find the best, most credible, most accurate, and reliable, most verifiable sources of information for what you're going to use to inform and guide the public that listen to you. That's what a professional should do. So if you're a media representative, I'm hoping that you are not attending to the mis and disinformation channels of the media. I hope that um, if you have a large portion of your audience that are that you know are anti-vaxxers or anti-physical distancers or anti-maskers, um, then perhaps you ought to hold after you have attended a session of this kind, perhaps you ought to invite um, uh, public health professionals and representatives of those groups to come together to meet with you and provide you with their differences of opinion. Try to understand what the root causes on the one side are and the root causes, or the root sources of information on the other side are that lead to these differences in opinion. Clo- Closely held, sincerely held differences of opinion, but differences that can lead to illness and perhaps death for people.
Right. What about the social media? Like social media, unlike the mainstream media, that regulatory measures are really very, um, I mean, lightened as compared to the mainstream media. What about regulation of social media as well in that
Right.
sense?
Thanks so much for mentioning that. I again in the next to last slide there will be some links from CDC on guidance for health communication by social media. Um, Social media sources. What's the right terminology? Social media sites, owners, Facebook, Instagram, and so forth, um, are only now, thank goodness, beginning to, and in a country like the U.S., where our First Amendment rights are critically important, freedom of speech is critically important. Um, but these media sources, these social media sources, are finally, thank goodness, beginning to recognize that you can't yell fire in a theater, okay? And what's happening is um, people are using Instagram, Facebook, and other social media sources to yell fire in a theater. They are conveying misinformation and disinformation. They may be conveying it because they sincerely believe that it's true, but um, that does not mean that they should be able to use such a powerful tool to try to influence others with the inaccurate information that and potentially dangerous information that they believe in. So it's complicated. I'm sure in the U.S. There will be court. There are ongoing and will be court efforts to uh, make decisions about the limits of First Amendment rights in respect to yelling fire in a theater on vaccine hesitancy and physical distancing and masking and so forth. And I hope that will happen soon. But social media is wonderful, um, a fantastic source and um, technology, but comes with some serious possible health and safety problems.
Right. Thank you. So if you just join us, we are doing a webinar session on how to talk with the media and the public in a health crisis. And facilitator is Dr. Robert Bernstein, and he's an adjunct associate professor of global health at the Rollins School of Public Health, Emory University in the United States of America. It's been a pleasure, and we are really being educated. Personally, I'm really learning a lot, so that we don't take for granted the things that or how we communicate to the public in this pandemic. As I said earlier, if you are not joining us, that we're in a crisis. In any crisis, you find out that people taking and process and act on information differently than they would do in any other non-crisis situation. So it's very relevant the way you, communicate, or the way you release information to the public, especially in this COVID-19 pandemic. So if you just join us, we are still on with this webinar session. You can send in your questions via our comments page on Facebook at Prevent First Commission, or our YouTube channel as well. Or you can send in via Radio Power UA if you are listening via that channel as well. So just stay on as we proceed.
Thanks, Peter, for that update. So if you don't have any other questions for guides or rules 4 and 5, we'll go to the next slide.
Yes.
Okay, last two of the seven guides or rules for cardinal guides for effective health risk communication. Speak clearly and with compassion. Um, your um, your compassion, the strength of your conviction in respect to the accuracy and importance of what you have to say needs to be conveyed in how you say it and what you use in order to say it. Um, Visual aids can be really helpful, whether it's the use of cartoons or images like the one on the right hand side of the slide here. Um, Graphs, charts can be really helpful in making clear what you are trying to convey. So technical language about evidence and information about the design of a randomized controlled trial, about the epidemiology of the spread, about the virology of of the SARS CoV-2 virus, um, about the differences between antigen testing, antibody testing, all of these technical issues that are so important in understanding um, the reasons for um, uh, implementing public health interventions in the absence of a vaccine. All of these technical terms and so forth, um, you need to carefully use them or not use them and try to find a way to convey the evidence and information behind them in a way that makes sense and in a way that conveys your um, conviction that this is right and that is wrong. Um, so speak clearly and with compassion, and then plan carefully and evaluate the performance, the impact of what you have to say. When you're planning a single or a series of risk communication briefings, you also ought to be planning how you're going to monitor and evaluate, monitor the performance and evaluate the results of what you have to say. Because otherwise you're operating in a little bit of a vacuum of your own. You may think you did a fantastic job, that everybody would walk away from this discussion absolutely understanding what they need to do. But in fact, they may not have asked the questions that were in their mind, but they are not going to walk away and do what you would have hoped that they do. And the only way you're going to learn about that is to include in your planning for the contents and the delivery, the spokesperson, the audience targeting of an audience, and so forth. And at the bottom line, the contents of what you have to say. The only way you're going to really know whether or not you did a good job and made a difference is to monitor the performance of what you have to say and evaluate the results of what you have to say. Um, so you need to develop some way of some indicators and a way to collect data about those indicators. You might, for example, have key informants in an audience, or you might have um, a focus group discussion afterwards with representatives of the target groups from the audience and see how they reacted to what you had to say. Oops, are you muted, Peter?
Right. I was saying that very significant for me, especially is the the side of being compassionate, or I mean, more so empathetic as well. Because in this situation, I think people get to receive and act on messages that you put out there. If they see that you acknowledge their fear, you acknowledge their pain, in fact, you acknowledge the suffering that they are going through, that. Right. So I think is very significant. Maybe you may want to elaborate more on some of the things that you can use to show your empathy. You can use to show your compassion. For people to get to know that. You feel the level of uncertainty that they are in, or the level of suffering that they are in. Actually.
Yeah, perfect. Thanks so much for that suggestion. Um, what you, among the tools, if you will, quote unquote tools, you might employ besides charts and graphs and so forth, are personal tools. You might bring with you um, individuals who were infected and became ill and perhaps seriously ill and were um, identified early and referred early and treated well and recovered, and you would work with them in advance to hopefully to emphasize their understanding and appreciation that what took place might have been prevented if they had been adhering to non-pharmaceutical preventive interventions, which they probably had not been. You might also bring individuals along who from different groups that are leaders of the targeted audience that you have invited for the briefing that you're holding. I mean, for example, if it was a briefing for the spectrum of faith-based organizations, you might have a rabbi and a priest an imam alongside you to give their perspectives on what you advise. Um, so thanks so much for mentioning that. Those are excellent tools. Um, that I don't mean to refer to the individuals as tools, but those are important ways in which you might humanize and increase the empathetic um, nature of your compassion and conviction.
Right, right. And we have an audience who wants to find out about the fact that, in this COVID-19 situation where we have scientific facts and uncertainties really, moving at a very fast pace. At any time, you find out that new facts are coming on board, which are scientific in nature, which we have different uncertainties also, building up in our localities as well. How should a communicator react to that? Because you'll find out that you come out to make a statement and the next day you find out you need to retract it or you need to improve on that statement. So how do the communicator really go ahead with that?
Okay. Well, the last slide is two suggestions of scenario-based training that might be organized either at the medical school or some other venue, and that could be used to address this. But basically, we come back to the first slide, the quotation in the first slide, that uncertainty. Science is not perfect. There is always going to be uncertainty, whether it's uncertainty in terms of a range around an estimate, a confidence interval around an estimate of the risk of mortality or the rate of occurrence in um, an ethnic group or a racial group, um, uh, to demonstrate that there are higher risks among some individuals than others, either for infection or for severity of disease if infected. Um, so uncertainty is certainly something that needs to be included in any briefing on the recommendations of what to do, what not to do. Um, if there are, as there are now, how many, 13 or more clinical trials taking place, randomized clinical trials, I think 6 of which WHO is sponsoring um, or involved in. The, there's a lot of uncertainty up front about how best to design such trials, let alone um, how, as the trials proceed, how to interpret early results and final results of trials. It's going to be enormously important for um, people who have the responsibility to do health risk communication briefings to be keeping track of what the WHO and NIH have to say about the progress of these trials, what CDC, NIH, and WHO have to say about the progress of these. And I don't mean to ignore the work being done, for example, in London by the the university, uh, is it blocking terrible? Oh my god! Um, by universities in the U.S. and in other countries that are also managing some of these trials, but people who are going to be responsible to do briefings on the progress and the results of these trials need to be paying attention to credible sources of information about what is taking place and what's being found and what's not known yet or what's not clear yet. One of the clearest things about randomized clinical trials is that they have to be held in relatively small compared to the global population or the national population of countries. They have to be held in among relatively small populations, and those populations may not be representative entirely of all the people who ultimately will be offered the resulting vaccine. So the safety and effectiveness of a vaccine after a clinical trial has to be monitored and surveilled post immunization, post vaccine surveillance will be critically important to ensure that what was found in a relatively small, possibly non-representative population that took place in a randomized clinical trial is actually true for the broader population that finally gets the vaccinations. So uncertainty is certainly something that health communicators need to be able to convey.
Right, right. And before we go to the next slide, we really want to throw more light or some few minutes light on the CDC's scientific communication guidelines, and especially its imperative nature for accuracy and also the way it's fighting misinformation. I believe that some policymakers may want to kind of replicate that in their system and all that. Is there anything you may want to talk about the CDC's scientific communication guidelines?
Well, the next to last slide, and I guess it's going to be the next one,
All
has a
right.
number of links to CDC websites where those kinds of details are provided in much more detail.
All right. All right.
Um, Having worked for CDC for 23 years and then a couple more years, I have the greatest respect for that organization, which unfortunately is under terrible political pressure from time to time, but nevertheless is my go-to organization when I want to identify the best available information from a public health perspective, or WHO, to go to WHO or NIH as well. But you'll see some links on the next slide that I think will be useful for what you or your audience is interested in.
Okay, okay. So I think we can proceed then.
Okey-doke. So come back to the purpose of a health risk communication briefing. They need to be clear. They need to be consistent. The communication from city one and city two and county three and state four should in one state should be consistent, I would hope. There should be, some consideration of differences in the nature of the populations in those different areas, but the underlying messages, if we're talking about non-pharmaceutical public health interventions and healthcare and preventing healthcare associated infections with universal infection control measures, so all of those things should be should be clear. There needs to be a point of contact, a speaker, a spokesperson identified who is capable, knowledgeable of providing a clear, consistent SACO message, and and the worksheet that CDC has developed is a helpful tool once the purpose of communication, a briefing has been determined, and the evidence and information necessary to develop it has been obtained, including, if appropriate, in meetings with key informants um, and focus group discussions, in order to make sure that the public perspective is represented in the SACO. Um, there's a link there for the SACO web sheet. And then there are a number of additional resources, including several that you've asked about earlier. And I'm not going to apologize, but I'll just reemphasize that I depend very much on websites provided by the Centers for Disease Control for the kind of um, accurate, verifiable evidence and information that I would need if I were asked to provide a briefing for someone. And this includes YouTube videos, um, toolkits for preparing social media information, guidance for communities, for schools, for workplaces, and various other audiences, public service announcements that a public health department, like a county or city health department, might want to prepare, or an organization like a faith-based organization or a workplace might want to prepare, and downloadable resources, and that includes posters that could be used in various settings, um, and of course guidance documents for state and local health departments, and for healthcare professionals, and for laboratories. And then using the example of waterborne outbreaks and waterborne communicable disease, or chemical or biological radiological hazards, using evidence from experience in developing water emergency briefings. CDC's put together the three links that are listed there as number 9. Um, and those links would help you develop a risk briefing for any topic um, by just applying similar principles. And finally, just in the last, gosh, I think it was a month or two ago, the Sabine Aspen Institute came out with a terrific um, document on vaccine hesitancy and what's known at the present time about how to go about it. Let me just get a little bit of coffee here. Sorry. What's known about the root causes of vaccine hesitancy, and the root causes of vaccine hesitancy in many cases are not very different than the root causes um, for hesitancy about physical distancing, masking, hand hygiene, respiratory hygiene, and so forth. So it's really quite a good document to have a look at if you have responsibility for developing health risk communication briefings. And I think that's it. Oh no, sorry. Here, so here are two. What shall I say? Um, Peter and I had some communication in advance of the webinar, and in the course of that communication, it occurred to me that it would be useful to follow the webinar with something more substantial, um, like scenario-based training exercises. So I proposed these two scenarios. How much time will you have left, Peter?
We still have about 30 minutes.
Wow. Well, I know that a lot of you folks are now at what, 10 o'clock in the evening, 9:30, 10 o'clock in the evening. So I don't want to drag this out too long, but the idea would be using one or the other of these scenarios, or on one session, one scenario, another session, another scenario. The idea would be for to establish groups, a risk communication group. Such a group might be a group of 3 to 5 medical students, perhaps more, but 3 to 5 might be great, with a faculty advisor. And that could be 3 to 5 members of a public health department or an employed population, um, and bring in an advisor or have a public health person from the organization um, serve as an advisor. And the idea would be to develop a risk communication with um, uh, three or three pieces of evidence. First, the websites and attachments that I provided, the SACO worksheet, and the 7 cardinal guidelines for risk communication. And the idea would be to prepare 3 things. One would be a 1 page written COVID-19 health advisory. Um, the second would be a 2 minute video health advisory, kind of a SACO advisory, but in a video format. Um, and the third would be to have a 5 minute question and answer session on the health advisory with an audience of other of peers. And so the 2 scenarios I proposed that might be used, one would be um, a scenario to consider the importance and the validity of public health interventions, non-pharmaceutical interventions, in the absence of a safe and effective vaccine, and to have a health briefing on the to try to overcome mis and disinformation basically about public health interventions. The second scenario might be a post-vaccine or close to the um, uh, final results to be disseminated and vaccination to begin for what has been determined by proper authorities, whether it's NIH or WHO or UK university or whoever, Johns Hopkins University or whatever organization carried out the randomized control trial in advance of the implementation. Might be useful to hold a scenario-based training for people who are going to be having to hold press conferences and briefings as the immunization program is implemented in order to address the questions that are in this second scenario, including some extra credit suggestions. Um, because, as I mentioned earlier, there would, of course, need to be um, post uh, implementation surveillance of adverse events for any new vaccine, and uh, and there might very well need to be a second year scenario. In fact, there might be a year-to-year scenario for a coronavirus vaccine, SARS coronavirus vaccine. So those are the two scenarios I would propose. There certainly could be others, and uh, I'd be delighted to be involved in implementing something like this wherever.
Right. So I think it's really a very nice one. We will, I think, because this program, of course, is partnered also with the European Medical Student Association, it will be quite easy to, partner with them to roll out such. So we will look into it and see how we can analyze this scenario and definitely get back to you with, whether or not it was a very good analysis of it or not.
Uh, I'm going to do one more thing, Peter, which I neglected to do, and
All right,
sorry for that. I'm going to put my email address down here.
all right, sure.
Um, so Can you see that?
Yes, I can see that.
Okay.
Maybe you may want to do it full screen so that our viewers can also see.
Okay.
Great.
So, are there any other questions? Any final questions from
There,
folks?
there are two final questions. Yeah. So I think the first question is, um, I mean, we had an audience who want to find out how, I mean, political leaders will be able to work with, I mean, scientific leaders, how they can amalgamate their effort to for the public good. Because I think what the audience drew my attention to the situation in Italy, where we had Italian officials attributing the spike in their cases to their missteps in responding to the particular pandemic due to tensions between protecting public health and also responding or respecting civil liberalities as well, and also maintaining the country's economy. So we are in a situation where how to, I mean, amalgamate the economy of the state, the emotions of the people, the rights of the people to even, I mean, and undergo this enhanced, I mean, social distancing, using of these, I mean, preventive measures and all that. So, I mean, which communication measures do you think should be effective for to combine the political enforcement with the scientific enforcement as
Wow. You're going to offer me a Nobel Prize for this answer? uh, I think we need to depend a lot on the World Health Organization to make a globally reasoned answer to that question. In fact, they together with Gavi, the vaccine initiative that Dr. Seth Berkley and others have organized with Gates Foundation support, and Dr. Tom Frieden, the former CDC director's Resolve to Save Lives website and organization. So WHO, Gates, and Resolve to Save Lives, all three of those organizations, and actually working together, I think are working to um, ensure the availability together with CDC and NIH and all other organizations, UK, Oxford University, I think I finally remember, um, are working together to make available accurate, verifiable, best available evidence and information. Um, Unfortunately, this pandemic has is so politicized in some locations, my own country in particular, that the 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 work that needs to be done is complicated um, uh, by that complication. And I'm hoping that that will change after November and January in our country. But also globally, I think the important thing is to pay attention to what the WHO and its partners have to say. Um, the Gates Foundation, WHO, Resolve to Save Lives, and universities like Hopkins and Oxford and so forth, Cambridge. Um, that's my answer. I don't have an answer to that question, but I trust those organizations to do that.
well. All right, all right. And the final question, I don't know if you want to respond to this actually, but an audience want to find out that do you think that the WHO, um, the WHO's communication has been effective, especially at the earlier parts of the pandemic when yeah, communication with the Chinese authorities and all that. What is your impression on that? An audience want to find out that.
Okay, I don't want to get in trouble, any more trouble than I already have with the U.S. Government and WHO. I was a WHO medical officer in Indonesia, and worked as a medical officer for UNICEF. So I'm familiar with the strengths and the challenges that organizations like WHO and UNICEF face in terms of the differences between the personnel that are working at the global level, headquarters levels, as contrasted with regional and country level. Um, the hiring and retention of WHO and UNICEF medical officers depends a lot on factors that may not always result in the best qualified individuals being in the most important positions. I think at the global level, that's not as big a problem as it sometimes is, in my experience, at the national or regional level. But bottom line, WHO is such an important organization and has done such important work in this regard. Um, Delays in its ability to take action because of the nature of its decision making processes, because of its membership, the membership nature of its organization, delays in its ability to take action has sometimes occurred. But the bottom line is that the actions and guidance that WHO has provided are correct, have been correct, um, and I'm sure will continue to be correct.
Great. I think that's it for the questions. Maybe you want to have final words to us.
Okay, anybody else? I hope that there'll be some follow up from this, Peter. And again, I congratulate you and Prevent First Commission and the European Medical Students Association. And thanks to Radio Power UA for putting this together. I hope that it will prove to be helpful for those who listen. And I look forward to getting the link so that I can share it with others.
Sure, sure, definitely. There should be a follow up to this. I mean, we'll be so glad to have you back with us in these webinar sessions. Uh, Definitely, we'll be talking to get to know how we can make that possible. But it's been a pleasure. For the impression we're having on our social media pages, reveal that people have really enjoyed, the audience have enjoyed the session, and I think it's really a great step to get people to be part of the fight against COVID-19 in the way they communicate with the public and even through the media as well. And it's such a great time. I mean, it's a pleasure to have had you. I know you are a very busy person, and to have made time for this is such an enormous pleasure to us. Such an enormous pleasure to us. Right.
No problem. Okay, thanks again. Looking forward to some follow up and looking forward to disseminating. Hopefully, talking about monitoring and evaluation, I hope what I had to say it will be useful for someone somewhere.
Absolutely.
And I'd love to hear if people want to share their experience in trying to use what I have to say.
Absolutely.
Please use my email address to do that.
Absolutely.
Do you have any idea what the size of the listening audience has been?
I may have to calculate and get back to you. I mean, when I send you the recording, I think I'll be able to come out with the exact people who were online with us.
Okay. All
Yeah.
right. All right. Take care. Stay safe
Thank
and
you very much.
healthy.
Yeah, so if you join us this evening for this webinar session, we had the pleasure to have Dr. Robert Bernstein, who's an adjunct associate professor of global health at the Rollins School of Public Health, Emory University. And it's been a pleasure to discuss and for him to facilitate on the topic how to talk with the media and public in a health crisis. Such an amazing time that we've had with him. Thank you for joining us this evening, and we'll come your way again with another interesting, exciting, and educative webinar very soon. And so stay tuned with us. Subscribe to our YouTube channel, Prevent First Commission. Just like and follow our Facebook page as well and get updated with many things that is being done here. Many thanks to the European Medical Student Association and Radio Power UA for helping us with this as well. Thank you and have a good night and good morning to those who are listening from other places as well.
Okay, thank you. Bye-bye.